So we're going to finish up the afternoon with a conversation around advancing interoperability, what we can expect in 2025. Jim Tate joins us again. With him are BJ Boyle of PointClickCare and Dr. Peter Schoch of No2. And No2 is also, of course, if you remember from Mickey, a QHIN.
Well, BJ and Dr. Schoch, afternoon here.
Good afternoon. Happy to be here.
You know,
so what I heard, Jim, is we have 6 or 7 hours if we want to fill. Good.
Well, you do, but we're going to compress it to 30 minutes.
All right.
We've been talking all day about interoperability. It's time to kind of talk a little bit about where we are and where we're going and outlook on 2025. So my first question is, what does interoperability look like in the future? We know TEFCA is part of that future, but is that the only path forward? Are all our eggs in the TEFCA basket?
Yeah, and maybe I'll start with that one, BJ, and we can kind of ping off that, and I'll just give a kind of a broad overview, really around interoperability. So I think I look at interoperability as a simple provider that it's data movement and data magic. Data movement means being connected to other parts of the healthcare ecosystem to facilitate clinical data moving at the point of care for the purposes of treatment, payment operations, individual access, et cetera. And data magic, what happens when our partners, technology partners, EHR partners, ingest that data and then work on that data to present it in a format that is in the provider's workflow and presented at the right time to aid in clinical decision-making and clinical operations. So that's kind of our definition of interoperability. And I think the best hope of interoperability is national exchange, some form of national exchange. And we've had national exchange in the past, and we've had private efforts and private networks, Commonwealth, Carequality, and others, direct secure messaging in the past, to try and accomplish interoperability, and they've moved the ball significantly forward. However, with the advent of TEFCA, Trusted Exchange Framework and Common Agreement, for those who may not be completely familiar with the acronym, and the Qualified Health Information Networks, or QHINs, that sit underneath that framework, we have, I think, a public-private partnership that is federally endorsed, and I'll talk about what that means here in just a second, that is a potential ubiquitous technical platform and trust framework to allow national exchange at scale like we've never had before. A lot of excitement in 2024 as all 7 QHINs went live. Another couple of QHINs joined the mix as candidate QHINs. And TEFCA was established and started exchange in July of 2024. We've had adoption in TEFCA and exchange in TEFCA. We've had commitments to health systems and some of the large data holders moving into TEFCA across the healthcare ecosystem. And then all of a sudden in November, this little thing happened called an election. And I think it concerned everybody because we have a significant, I think, change in leadership and administration. And I just want to say a couple of things. I don't think anybody has a crystal ball about what 2025 has in store for interoperability in TEFCA, but I will tell you what I think the market forces are telling us that I think is somewhat reassuring. And Mickey may have commented on this in an earlier presentation. Number one, healthcare needs interoperability. Interoperability is foundational to solving healthcare's biggest problems, whether it's provider shortage, provider experience, whether it's patient experience, patient outcomes, whether it's cost of care. Interoperability has a role to play in solving those problems. Number two, because of an aging population in this country and the stress that that's going to put on the health system economically, namely the federal government, the largest purchaser of healthcare, there is an inevitable movement toward value-based care, accountable care relationships. And I think the new administration has historically talked about privatization of Medicare, which means moving toward Medicare Advantage and more accountable care plans. Now, has good and bad, won't debate all the good and bad in that regard, but value-based care needs interoperability to be successful. We can't lower costs the way we should. We can't deliver high-quality outcomes the way we should if we're not interoperable, sharing clinical information for the point of decision-making clinical outcomes. Why do I think TEFCA is probably here to stay as the national framework? A couple of things. Number one is because if value-based care is inevitable and interoperability is inevitable to help us succeed in value-based care, TEFCA is probably the best framework and the best opportunity, taking all the learnings of our prior networks and prior efforts, combining them into a single ubiquitous national trust framework and technical framework to allow for all forms of exchange for all purposes of use. So number one, that case. Secondly, TEFCA has already made it into legislative action, meaning that it was born out of the Cures Act in 2016 that had bipartisan support moving forward and has largely marched forward since that time. Some administrations slower than others, and Mickey has accelerated that to establish TEFCA. TEFCA is also now established in federal regulations in other areas, most recently the HTI 2 drop that really established the vetting process into regulatory rule for the vetting process for QHINs, et cetera. So I think there's a lot of work that's been done to establish TEFCA's place in the national exchange, in the future of national exchange, in the future of interoperability. And I don't see, given the market forces that face us, that will be necessarily undone. Again, no crystal ball, but I think if I look at the market forces, what's happening in healthcare, interoperability's role there, what TEFCA brings to interoperability and what TEFCA means for interoperability, I think TEFCA is here to stay in some form or another moving into 2025 and beyond. I also think if you just look out in the market and see the commitments of large technology vendors like PCC and others, there is a belief that TEFCA offers a form of national exchange that heretofore may not have been quite as ubiquitous or hopeful. So I'll pause there, and I'm sorry if that was long-winded, but I want to make sure we hit those individual points as we move forward.
Thank you, BJ. Yeah.
I think Peter expressed it spot on. I may add a few different things, maybe from EHR and a technology perspective, which is stole my thunder a little bit, but I just think, if you look at value-based care and in how that's evolving, the simplest way that we think about it a lot is I want to provide the highest quality care with the best possible outcomes with the lowest cost. And I think lowest cost translates into the least amount of friction and disruption in any single patient's healthcare journey. And I'm not sure I need a federal program to necessarily have to make me want to do that. I think the incentives are there now. What we need is these federal programs to help ease that friction, to make sure that we have that federal standard to be able to do that. And so I think that's here to stay. I think that if you look at the value-based care programs, they've taken a lot of the low-hanging fruit out of the system right now, and we need to drive interoperability. And I think the second part that I would add, and I really like the data magic component of this, but I will say the reality is as a technology engine behind a lot of our customers, we have to be prepared and equipped to handle data and interoperability through lots of different methods. Obviously, we prefer and we are strong believers of a federal standard because we think that greases the wheels a bit. But I think we also have to be prepared, and 2025 still is going to have, whether we're working locally with the states or in some cases sort of traditional API methodology, but and then you look at TEFCA and other federal national frameworks, all really important to how we help solve those problems.
Here's kind of I don't challenge it in the right word, but I'll use a metaphor. In the early 1980s, I guess it was, IBM came out with a software word processor. Everybody threw their typewriters away because of not because it was the best practice, but it was, people would look at it and say, "Give me one of those. I don't want to use a typewriter anymore." So for providers to sustain widespread national adoption of a TEFCA or TEFCA-like network, I'm really glad we got a QHIN to talk to and an EHR vendor to do that. So the the QHIN will be able to be queried and bring that data to the edge of the EHR. The EHR's got to do something with that data, and the providers need to see overwhelming benefit of it for it to be truly adopted. Now, in the EHR world, technology, it was the ability to do e-prescriptions. As soon as providers saw that, they said, "I want that." So what can we do, or maybe it's already being done, because there's got to be some kind of handshaking that's not only technical, but workflow and process for providers to say, I'm going to start using that on every patient.
Totally agree. Maybe I'll jump in first and then
Please.
Yeah.
maybe you can add to that. This is a topic we could probably talk for a really long time on. I personally get frustrated over the years where we are checking regulatory boxes and say, congratulations, we're interoperable, yet nobody does anything with it, right? I can tell you lots of
Yes.
stories, even on transitions of care. 5 years ago, one of the things I'd hear about was that when a resident left a skilled nursing facility to go to the emergency department, that all it was a fax or a packet that was with them on the ambulance, and there was this black hole and nobody looked at it. And with partnership with groups like No2 and others, we've solved a lot of that problem. And now what I hear is you replace nothing with a 53-page PDF that I don't look at either. And so while we've accomplished one thing, we haven't really accomplished the end game, which is when someone shows up at the hospital at the ED, I want to see a quick summarization of why they're there. And so why I think this is really important is one of many examples is, we need interoperability, for example, to drive. We have an AI tool right now that's actually giving the reason for transfer based off that documentation. You can still go look at it if you want, but we have to take the extra steps out of the process. And so whether that's at transitions of care, your med reconciliation is another really strong example. Just, when someone transitions from one place to the other, how do I get rid of those manual errors? So I encourage, one of the things we look at is how do we eliminate the number of steps that they're taking, right? How do we just empower the process? Because those nurse and direct care staff have too much time, don't have any time to waste. So Peter.
Yeah, no, I love that, BJ, and I think it was absolutely appropriate that you lead out on that, because I think that's where 90%, 80% of the magic happens is with what you guys do with it in the presentation to providers in their workflow, such that they can actually make good clinical decisions. I've often said as a provider, I don't need more data. Data is useless to me. It actually increases my cognitive burden and administrative burden. What I need is information that's delivered to me in my workflow in a way that is digestible in a timely manner, and then it becomes knowledge. And then knowledge over time, meaning that happening repeatedly, becomes wisdom that I can actually use to improve my practice overall, et cetera. So I think there's a lot to that. I do think there's 20% of data magic that can happen on the network side, where we're actually doing some things in transition of the data to you guys, where we're consolidating, deduplicating, things of that nature, so that there's less burden on you guys to take in data and then process it in a way that you can do differently. So I think it's a good partnership in that regard. But I really like where you went with. One of the things you said earlier in your previous answer, BJ, that you brought up that I also wanted to touch on, just this idea of being more frictionless in healthcare. Healthcare, as it has evolved and will continue to evolve to get closer to the patient in the home with new and innovative care models, will naturally increase the fragmentation in healthcare, specialization, moving closer to the patient. The only thing that overcomes that fragmentation is the right information, right place, right time, in a manner that physicians, that any provider, when I say provider here, I don't mean physicians, I mean anybody on the front lines delivering care, whatever their role, can digest and use in a cogent manner. So I just want to emphasize that point, because that is a really important point.
Yeah, totally.
So is TEFCA the end game? What's the world going to be like in let's say TEFCA is widely accepted. What's the post TEFCA world going to look like, or is that the pot of gold?
Yeah, I'll give you two viewpoints, and one's probably a bit self-serving. I think that what we have always believed at No2 is that interoperability, and BJ alluded to this, isn't a single standard and isn't a single methodology. So we have created a full stack healthcare communication infrastructure that's agnostic to content and agnostic, for the most part, to the methodology. So through a simple API integration, send, receive, and find, whether it's PDF, whether it's fax, whether it's HL7, whether it's FHIR, any of those things can be transmitted that way. And I think that's going to continue to happen. I do believe that TEFCA is the next advance in national health exchange. How long TEFCA exists before it's iterated upon, and the learnings from putting TEFCA together, I think is anybody's guess. I think the pace of change in technology only accelerates, and I don't think that's going to be I don't think TEFCA is going to be unique in that. But I do think it's here to stay, and I do think there is a platform right now in the technical framework and in the common and in the trust framework to be a ubiquitous form of exchange for the next several years, maybe iterated on. How it's funded may be iterated on depending upon the administration, but I think that part is here to stay. So
I agree. I would just maybe add a bit that the challenge is I think any of these networks, and we see this even with Carequality or others, where the network's as valuable as the volume and majority of participants.
Yeah.
And I think, we've experienced where 4 or 5 years ago, we went and put all of our post-acute providers on, made it available for them to go on Carequality for free, no additional charge. We want to empower that for lots of reasons. In certain regional areas, it's been awesome. They couldn't live without it. In other areas, just happens that their referral partners aren't very active on that, and so there may be other ways we have to go. So I think that the goal here is, do we have this framework? We do think it's going, but how do we drive adoption so that we're at that critical mass that it drives what we want?
yeah, and before we move on, that is the critical step to me. I think it is one thing, and we talk about this all the time, and I'm sure BJ has heard us talk about it with his group, is that there is this, I think, false sense of success that interoperability has been solved through Commonwealth Carequality, DSM, and now TEFCA for the purpose of treatment. And what I mean by that false sense of security is we have a ton of technological adoption to national exchange, meaning that we are probably more adopted across technological platforms, EHRs and other platforms in healthcare than we have ever been in the history of interoperability. But what BJ's talking about is the next level of adoption that actually delivers the value and impact of interoperability at the point of care. And that is the edge being adopted. That is providers understanding that I can improve my provider experience by decreasing administrative burden, quicker decisions, better decisions. I can improve the patient's safety by having an accurate medication and allergy list, et cetera. And I need to change my workflows to do so. And on and on and on. That's where the impact's felt. And that's the next level adoption. I think that's the work that I love partnering with PCC and the teams to make sure that we're getting it down to that granular level so that they want the value, see the value, want it, and then won't live without it.
Yeah, I was just, this was we on the EHR standpoint, our majority of customers are in the post-acute space who wouldn't say they would naturally be the ones pushing these conversations. I was with a customer last week who was telling me that they went to their hospital and said, "Why are you not on Carequality or sharing on the network?
Love
We need
it.
this."
Yeah.
And that's not I've not heard that before, right? I don't think that they've been empowered to do that, but they see this significant drop off in time savings and accuracy and quality transitions for those who are sharing data or they're not. And so I think that that's the point here. And it's also where I think that value-based care carrot is also really important, because it's not just about the federal sort of carrot or the stick. I think there's quality and financial reasons with these other models too.
Yeah,
Well,
it's funny. Oh, I'm sorry. It's funny, BJ,
No, go
just
ahead.
as you say that, because I think it's incredibly important for people to understand that the post-acute space it's an outdated term. It's a completely outdated term.
Yep,
But the
yep.
post-acute space, which is what everybody kind of calls it, has often been kind of the forgotten part of the healthcare system, right? Not emphasized in meaningful use with technology adoption and so forth.
Yep.
It will play the biggest role it's ever had in the next 3 decades, as now we have the baby boomers aging into Medicare age, and post-acute services amongst that age group of folks from 62 to the end of life is going to go up dramatically. And you guys are going to have an unbelievably important role to play in information exchange and become as important a data holder as any health system or any system of record on the acute care side. In addition, your ability to transmit social determinants of health back into and across the
Sure.
ecosystem from your settings of care, unbelievable and unmatched potential to actually drive value-based care as well as just improvements in outcomes.
You know, we only have about 10 more minutes, and I mean, we really could go 2 or 3 hours on this. And so I hope we can continue this conversation at another time in another format and make it available. I have a lot more questions, but one question I have is around providers seeing benefit and trusting that benefit. So we've got a QHIN that delivers data to the edge of the EHR. That data is then, I guess, BJ, you could tell me, is available for the provider to view. And I guess they decide whether that data actually gets integrated into the patient's record, correct?
Yeah, I mean, I can tell you how we do it.
Yeah, tell me. Yeah.
Which is, I think, which is, you know, the first use case is, how do we solve the seamless transitions of care? And
Yes.
I can tell you, I think probably anybody on this call or in the healthcare space or any of us have had personal stories where we've got, you know, family members who've gone through this transition. I have a, you know, before I worked at PointClickCare, my grandmother had a stroke at the hospital, had to get transitioned to the rehab center. And on that and that's an emotional decision for the family. That's a tough decision, transition, of course. And all of her med lists didn't come over completely when it was transcribed from the fax machine they came through. And you know, that's an example where regardless of the payment models, that's just the not the right thing to do on that transition. Right. So what we think about is that when that admission starts, that we go out and query the networks or whatever connection we have, and we have that information teed up electronically so that nurse can do that med reconciliation, look at the diagnosis, have the pharmacy take a look. And so we just want to take out that manual process on that transition. That same way as I mentioned earlier, if someone leaves and heads to the hospital, they're doing that for a reason. We don't have time to then go track it down. And so I think we think about every step of that journey. We want to have that seamless flow go through. And so we're a little bit different because it's a transition, and oftentimes you're receiving care within that setting, and then they may transition back out. And so that's how we think about it. I would just, you know, we encourage our team, and I think many of our peers out here just to say, like, how do we eliminate unnecessary mistakes caused by manual steps, right? Let's streamline that wherever we can.
Peter, your thoughts on that?
Yeah, I echo what BJ said. I think he stimulated a thought in me that as he was talking around some of that work and transitions of care and so forth. I think it's value-based care is, and this is strange because I don't think we use it this way, but value-based care is really irrespective of the payment model or the reimbursement model. All the care we deliver should be value-based, meaning that we should be driving value, whether it's a fee-for-service transition of care or a transition of care of a patient in some value-based contract where the provider is at risk for the outcomes from a financial perspective. I think interoperability and what BJ is talking about of removing friction points, removing the unnecessary steps is applicable across healthcare, whether it is value-based contracting or fee-for-service reimbursement model. It's all supporting value-based care delivery, which I think is incredibly important.
We only, excuse me, have about 5 more minutes here. So it's time for me to ask this question for discussion. In terms of interoperability and the trajectory of interoperability. I guess the beginning of interoperability was, as BJ, you mentioned, I believe people showing up with a stack of papers, and then we had fax machines, RIOs, HIEs, TEFCA. I don't know what else, but it seemed to me that maybe 5 years ago, we thought that there was going to be a pot of gold that we would finally get to. I don't know if there's a pot of gold there. I don't know. This may be a process. Again, you know, genomic testing, stuff like that. That's not even part of what's being exchanged now. It's not part of the US CDI or things like that. So there's going to be ongoing development. But I'll kind of go back to, there was an actual trajectory for the adoption and meaningful use of EHRs in terms of interoperability, not only the technical side, but the actual use side of it. Where are we in the trajectory? Is it still breakfast, or are we after dinner, or somewhere in between? That's my
Well,
question for you too.
yeah, and BJ, feel free to chime in, but I think from my perspective, I think it depends upon what level of adoption you're talking about. Are we talking about technological adoption, or are we talking about edge adoption? Because I think we're at two different. I think there are two different trajectories there. Number two, I think that if I look at the overall trajectory of interoperability, and understand everything that goes with it, meaning that interoperability to me is data movement and data magic, as I said earlier. I think we have to get connected, and I think we're at a point now where we have provided an infrastructure. And I think the greatest thing that came from meaningful use, we can demonize a lot of different things, and I certainly have been an advocate for the post-acute space, that they didn't get funding, and we need to do things to make sure that we can move them forward in the same ways that we moved others forward. But the reality of it is there was an infrastructure built with that, and we took our lumps. We learned a lot in that process, and I think we've taken all those learnings and put them in to TEFCA. Again, is TEFCA perfect? It's not going to be perfect by any stretch of the imagination. It's going to need to be iterated on, but it's the best of all we've done in the past, rolled up into a common technical framework that I think allows the acceleration of technical adoption and potentially the acceleration of edge adoption in ways that we haven't before. The other thing is, because we've got the connectivity and the infrastructure kind of laid, it's not perfect. Again, we can talk about data usability standards and all the things that we generally talk about, looking for perfection. We can still make significant progress in adoption by now shifting the conversation from technological connection of EHRs and platforms, which we have a mechanism now to do, and a national framework for exchange, and move it to what is the impact that the end user is going to feel by becoming interoperable. And that, I think, will drive the edge adoption, which is where the magic happens. I think you reach a critical mass of edge adoption, and all of a sudden people go, my God, how did I live without this? It would be, our providers now are living in a world where they're going into Best Buy and they're buying a laptop that doesn't have Wi-Fi. That seems absolutely insane, right? And I think we've moved past that point now, as we see, as BJ said, they gave Carequality away because they saw it was important 5 years ago. As we continue to move to that point, now we've got the technology built. Now it's talking to them about the impact and what it does for their business, for their patients, for their own lifestyle. And I think that will increase adoption. Sorry to be so long-winded. BJ?
No. Yeah. BJ, your thoughts?
I'm trying to figure out where I'd be in the meal analogy. Maybe we're at appetizers, Jim.
Okay.
I can share a little sentiment that I think that I've noticed a shift in maybe a challenge at the same time. I've been in the industry for a long time in different roles, and many of the attendees here have, of course. And I think interoperability for a long time was a pretty technical, tech engineering conversation. Let's get the IT teams in. I remember 10, 15 years ago, every booth at HIMSS would have some version of interoperability, and that's where you'd put the tech teams. I'm seeing a shift that, like, we're hearing from our end users, not so much tell me what the US CDI has. It's when someone shows up at my building, I want to have all the information. Or how's come when I send a secure message to the doc, I can't just include the following, fields so that they can see it and send back. And so I think that's representing a bit of a crossover with us, where we're starting to get requests from the end users on making strong impact, and the tech is just a byproduct, right? I mean, if you think about anything we consume, we subscribe to all these streaming services. None of us really care how they're getting there. I just want to see all the movies on there, right? And I think that's where we're starting to get to. So I'm optimistic that's how we start to push the lever next.
Okay. Critical mass. I'm looking forward to critical mass. Well, gentlemen, we've run out of time. I hope we get to continue this conversation maybe in the new year, after we see what's going to happen from a policy standpoint. But Peter and BJ, thanks for your time today and your comments.
Thank you, Jim. Appreciate it.
Thanks so much.
Thank you, Jim, very much. Thank you, BJ.
Enjoyed it.